again. We are very grateful for your presence and your generosity, Patricia. And colleagues, please do take the opportunity to debate with her, to ask hard questions, and make sure that it's gonna follow up, conversation. With that, I would like to end, and I wish you all fruitful deliberation. Suhaila, back to you. Thank you.
Thank you, Dr. Fuji, for your thoughtful words. Your message lays a strong foundation for today's discussion. Ladies and gentlemen, with that, we now officially open today's session. Once again, thank you to all our distinguished guests and participants for joining us today. Before we continue, here are a few quick housekeeping reminders to help ensure a smooth session. Please turn on your camera. Please keep your microphone muted unless you are invited to speak. This session is conducted in English. If you need support in understanding, feel free to turn on the closed caption on Zoom. We encourage your active participations. To join the discussion, please use the raise hand feature or type your question in the chat box. We will prioritize the live question during the Q&A, followed by the selected written ones. You are welcome to ask questions in either English or Bahasa Indonesia. The moderator will assist with translation when needed. Please note that this session is being recorded for documentation purposes. We now move to the main part of our program. It is my pleasure to invite our moderator, Maria Esterilita STR-SOS SPPSA, known as Ibu Mari. She is a lecturer in Social Welfare Study Program at Binawan University since 2018. She is a certified social worker. She has received research and community service grants, and her work focuses on children, families, palliative care, psychosocial therapy. She has published books such as Telehealth in Palliative Care and was named the best oral presenter at the 2024 Second World Conference on Health and Social Science. We are very honored to have her with us today. Without further ado, I hand over the screen to Ibu Mari.
Okay, thank you, Miss Suhaila. Is it my voice clear? Okay.
Yeah, it's
Hello.
clear.
Okay, thank you. Hello, good evening, everyone. Welcome to today's session in the Social Work International Lecture Series. I'm Mary, and I have the great pleasure of serving as your moderator for this important webinar with the title Reclaiming the Role of Social Workers in Health, the Billing System, Integration, and Beyond. We would like to warmly welcome our distinguished speakers, Dr. Patricia Welselebi. A special welcome to representative from the Ministry of Social Affairs, Indonesian National Council of Social Welfare, Dr. Puji Pujiono, Ms. Virolia Pramadita Putri, Chairperson of the Indonesian Association of Medical Social Workers, and our thanks to our university partners, UMJ, UIN in Jakarta, Binawan University, University of Indonesia, and Pajajaran University. And of course, to all distinguished participants, the social workers, lecturers, students, and humanitarian workers joining us on Zoom and YouTube. Thank you for being with us and taking the time to be here. To the participant, you can write in the chat column where you come from. And I hope you can enjoy and get some insightful and join the webinar until the end session. I will guide you through this discussion. I will open a question and answer session at the end of the presentation. If you like to ask questions directly, please do in the Q&A session. And if you prefer to ask questions via the chat box, please write your name, underscore institution, underscore question. And open floor for the first 3 participants to ask live question. And if there is still enough time, we will open a second session for another 3 questions. Okay, and I will starting this topic. As you know, social workers play a crucial role in supporting patients, families, communities, and particularly in healthcare settings. However, despite their impact, social workers are often excluded from hospital billing, health data system, and policy framework. And this session explore how classification system like ICD, ICF, and ICHI can support greater inclusion of social workers into the global healthcare ecosystem. We cannot wait to hear explanation from Dr. Patricia and see what the strategies and the steps must be taken in the future. To guide us through this topic, we are honored to welcome a distinguished expert, Dr. Patricia Wells-Celebi. Hello, Dr. Patricia, how are you today?
I'm fine. Thank you so much for having me. It's an honor to be here as your speaker today.
Thank you very much. And I know Dr. Patricia have a long curriculum vitae and experience, but I will to share the shortest one. Dr. Patricia Wells-Celebi, a renowned expert in the International Classification of Functioning, Disability and Health. She serves as chair of the Department of Director of Social Work at Bradley University in the USA. She is leading authority on the International Classification of Functioning, Disability and Health in the field of social work. She specializes in applying the capability approach as an alternative framework for understanding disability. She currently serves as collaborating member of the WHO Education and Implementation Committee for International Classification and the WHO Functioning and Disability Reference Group. Her research focused on enhancing functioning, health, and social care across both local and global contexts. This includes utilizing the capability approach to deepen understanding of disability, chronic illness, and health conditions, promoting the use of WHO classifications such as ICD, ICF, and ICHI, and contributing to the development of national standards to improve interoperability of health data systems. And I have already followed you in the LinkedIn and Instagram, Dr. Patricia. And we will enter the main session. Please welcome Dr. Patricia Wells-Celebi. Your time is about 40 minutes. The screen is yours.
Thank you again so much for that warm introduction. It is an honor, as I already mentioned, to be here and to be your speaker for this month and this amazing international lecture series. I will go ahead and share my screen if someone would be able to confirm that you can see the slides.
Yes.
Excellent.
Okay.
Yeah. Fabulous. Thank you so much. So today, as mentioned by our esteemed moderator, the title of my presentation is Reclaiming the Role of Social Workers in Healthcare. This is not a new issue. It is not an issue that is unique to Indonesia. It is an issue that social workers around the globe face. We, as a profession, are frequently overshadowed, and we are left to the side, if you will. We do not necessarily get considered when we're thinking about interprofessional care, thinking about care within healthcare settings. And I say healthcare very broadly to mean both health, mental health, behavioral health, and so forth. However, we know that we add value to the healthcare team, and we do it in a number of ways, but certainly directly and indirectly, we have evidence, and increasingly we are identifying the return on investment, if you will, of integrating social workers within healthcare. So I think as we continue to see social workers partnering, let's say with health economists, for example, with hospital administrators, with business individuals, we are seeing this data come out, which will serve us quite well. And this will supplement, of course, all the anecdotal stories that we can share as frontline workers in the healthcare system. So today I'm going to situate my talk about how we can utilize a series of health classifications developed by the World Health Organization to serve our mission, our cause, to reclaiming our role within healthcare. And I'm going to talk about how that relates to a growing concern in global health systems, which is data comparability or health interoperability. And then I will provide some resources at the end of programs, training programs, for example, of ways that I have been able to integrate social work within interdisciplinary teams and be able to better position social workers through training in the healthcare systems. So I hope this is acceptable to everyone in the audience. If there is something that I mentioned that you would like additional information, please don't hesitate to ask me at the end of the presentation. And I also, I have more slides than I could share within the time allotted to me today, more information. So I'm always happy if you connect with me. I will share at the end my connection information through LinkedIn and email. Please do not hesitate to contact me for additional information as well. So this is a slide that shows the WHO or World Health Organization family of international classifications. The network is called the WHO-FIC officially. And you'll see in the center, we call this the reference classifications. Reference classifications are the primary classifications that WHO manages and maintains. You'll see there is a blue book, and it's called the ICD-11. So I'm going to talk today a little bit about that classification. It's our international classification of diseases, and we primarily use it in healthcare systems for diagnostic processes. We also have it crosswalked in the United States for mental health disorders. We use something called the DSM. We have the ICD-11 crosswalked to the DSM currently. There is also a modification you see of the ICD, the previous version, which is ICD-10. We used in the United States clinical modification of this classification. However, not all countries use it. They use the actual ICD in and of itself, and the ICD-11 is not able to be modified. So as the United States transitions to ICD-11, we will be using it without a clinical modification. The red book that you see in the center is the primary classification that I would like to talk to today. It's the International Classification of Functioning Disability and Health. This is a classification that I helped to develop in the late 1990s, and it focuses on functioning and also has a series of environmental codes within the classification. So I will talk about this relevance, of course, for social work, since we focus so much of our work on functioning. And then the brown book that's toward the bottom is the International Classifications of Health Interventions. This is the newest classification released just a few years ago, and it has information about all types of health interventions, including those that are relevant to social work. So we'll talk a little bit about this through the bulk of my presentation, but I wanted to introduce you to the family of classifications. And also we have to the left, and I know this is situational, it might be to the right of your screen, but to the left, we have related classifications. These are additional classifications that have been developed. They pull some information from the reference classifications, but they stand alone often because they serve a purpose, like primary care, for example, or nursing practice. We also have one that's the ISO 9999, which is our technical aids for persons with disabilities. And then we have classifications that are derived. They kind of come from the main classifications. So like our classification for oncology. So if you're working in cancer care, we have the ICD-10, as I mentioned, the classification modified for mental behavioral disorders and so forth. We have one for neurology. So you can see these, and these are all readily available on the WHO website. So you can Google it and you can find it. And if you have difficulty in any way, please do not hesitate to call me. So we go back, and I'm just going to reiterate the three main classifications, which will be the focus of my talk today, which is the ICD that is used for diagnosis, the ICF, where we're able to capture functioning and environment information, and the ICHI, which is the classification of focuses on health and interventions. And this link at the slides will be made available to everyone afterwards, but nevertheless, the link is shown here at the end of the slide, but it is easily Googleable, if you will, to find it online. It will direct you to the classifications as well as additional information, training information. So there's a lot of information, a wealth of information that you can utilize to learn more about the classifications. So what is the ICD? I mentioned it very briefly. Our formal title is the Statistical Classification of Diseases and Related Health Problems. It is the international standard for systematic recording, reporting, analysis, interpretation, and comparison of morbidity and mortality data. So many countries use this. For example, we're capturing on the death certificate the reason for the death. That mortality data is used at a national level, and then it is used to compare from country to country. So we can start to look at trend data and so forth. We use this, for example, more recently when we were looking at COVID to be able to determine the number of deaths associated with COVID and to compare that at a national scale. We look at morbidity data as well, but in the United States, as well as some other countries, we are really looking at functioning now as a third indicator, a major third indicator, which is great. It's been a long time coming, but it's something very useful for social work. And the ICD is used, as I mentioned, and not only to capture that kind of data at a national level through ministries of health, or in our case, United States, through our CDC and our National Center for Health Statistics, but we also use the ICD for clinical care, for billing specifically, for third-party payments and insurance payouts, primary care, public health, research, and statistics. So it's a very versatile system. It has been integrated into multiple countries. It has been translated into a number of languages. It is well used, and as I mentioned already, it's in its 11th version right now. This graphic, you can see some of the ways that we use the ICD-11 globally. I just wanted a nice quote here from WHO that the classification and the terminology, because the terminology is what makes sense within the classification and that hierarchical structure, allows the systematic recording, analysis, interpretation, and comparison, as I mentioned, of mortality and morbidity data collected in different countries or regions and at different times. So it isn't just one kind of cross-sectional point in time. We are able to utilize it to look at longitudinal data as well. It ensures the semantic interoperability and reusability of recorded data for different use cases beyond just health statistics. And this includes decision support, decision support, resource allocation, reimbursement guidelines, and more. So we are using the ICD-11 when we have a consistent framework that is used from country to country. It makes sense when we want to look at data interoperability, right? So we're building these kind of large electronic health systems. We want to be able to use a terminology and classification that works in multiple countries so that we're able to share that information seamlessly. The ICD-11 is the latest version. This was approved in 2019 by the United Nations World Health Assembly, and it was scheduled for implementation on January 1st, 2022. In many countries, not many countries, but there are countries, large global health systems that have had some additional time, United States being one of them, to actually implement the ICD-11. As you can imagine, when you have such a large scale, it's very difficult to make the transition. So we are still working on this process. But the nice thing about ICD-11 is that it was developed to support electronic health records and digital data information systems. And that is where we are going, that direction we are going, as you know, globally. So we made sure that we created the infrastructure to more easily help countries make the transition. With that said, the ICD-11 is fully electronic. It provides access to over 17,000 diagnostic categories. With that, over 100,000 medical diagnostic index terms, because it's worked on a hierarchical system that starts at a higher level within a general domain and then breaks it down into more specific codes as you need it. And clinically, we often find ourselves breaking it down into more specific codes. I mentioned the clinical modification used in the United States. This is based on the previous version. We will be shifting to just using the ICD-11, which is a requirement of the WHO. And the ICD-11, actually, all three of these classifications, I want to make note, are freely available. They are open source classifications, and they come with an API to help facilitate the integration within your country's health system, electronic health system, and so forth. But in the United States, we also, why it's so complicated, because many people say, well, why isn't the United States using it? Because also we have built other systems based on the ICD previous version, like our PCS system, which is the procedure coding system. So when we have inpatient procedures, we have specific codes for those based on the ICD, and that's what is getting translated to and transmitted to within the hospital system to insurance companies and third-party payers. So we use it for a variety of reasons. Medical coders, for example, within our hospital systems, use it to assign codes to not only procedure information, but the diagnosis codes. And this is what is used for billing and claims and so forth. Okay. So it takes a lot when we're thinking about how we can, because we have these kind of legacy systems, and how we can actually transition, even though it is meant to have a seamless transition. It's not so easy when you have other systems that are built upon that system. So a lot of coordination and rationale why it's taking us some time to make the modification. I always like to include a photo within my presentation to kind of capture more of a visual element of what I'm talking about. So I've mentioned the ICD already in terms of why it is valuable for diagnosis and insurance billing and third-party payments. This photo, I think, can kind of help capture why we need to move, not necessarily away completely from diagnosis. We will always need that, but why we also need to complement and supplement that information with information related to functioning. So if you see this slide here, if you were in my classroom, I would ask for volunteers to describe the photo, but because of the nature of the talk, I'll just go ahead and describe. You'll see here, there is someone, we don't know too much about what we call the backstory or what this person actually is, who that person actually is, and how they identify. But you will see the person is using their feet to actually complete the embroidery that you see here, this beautiful piece of artwork. And so the idea is, if we have a diagnostic only based system, we might assume certain things associated with that person's diagnosis. And I don't know what this person's diagnosis is, but let's say the person had lost the ability to use their hands. I think it's probably safe to say that is the case here, because they had a stroke. Maybe there was an accident, maybe there's an injury, they're paraplegic. There's a variety of reasons why they might not be able to use their hands. And as a result of not being able to use their hands with that diagnosis, there are people, right, even in the healthcare profession, that would make assumptions that this person might not be able to do something like this, might not be able to engage in this activity. And they would be clearly wrong, because look at what this person is able to accomplish. So with a change in the mindset, and as we move away from diagnosis only to how we can help, how we can support people in terms of their functioning day to day, I think is important. And it's also important to understand what people would like, what their priorities are. So if this person were to say, I would like to learn how to embroider, and we judge that person and we assume they cannot based on that diagnosis, we would be mistaken, and we would basically cause that person probably quite amount of frustration, because if they want to learn something, they should be able to learn it. So it would be, how can we then provide an alternative, how we could provide an accommodation to make this happen, right? So a nice, hopefully visual case example for understanding why we need to move to the direction of functioning, functional care, functional status. So why is it relevant, aside from what I mentioned through that illustration of the case example? But we know that individuals with the same diagnosis, that means that they will have the same ICD code, exhibit different functioning levels. Yes, we can make some characteristics or characterization around someone who might have a particular condition with that expectation that they will function in a certain way or have difficulty in functioning in a certain way. But we do ourselves a disservice as clinical professionals by doing that, because we know we should be looking at that individual case one by one, and we should be taking that information in an assessment and then providing an intervention that is targeted to their respective needs. So if, for example, I was diagnosed with breast cancer and another person was diagnosed with breast cancer, our lives will be different. We know because our lives are shaped by so many different aspects, right, in our life situation. That ICD code is the same no matter what. It just has a single code that captures every person who has been diagnosed with breast cancer, and that is what is transmitted in the hospital medical billing insurance-based system. But it tells us really nothing about that individual or those individuals. And in terms of where functioning comes into play, it's when that person, once they have that diagnosis, is referred out to clinical professionals like social workers in many countries, but also occupational therapists, physical therapists, rehab professionals, and so forth. So we know consequently their needs are not the same. Their life situations require different types of interventions, and not only health medical interventions, but also social work and others. If you're working in a school, for example, and you are the school social worker, you may need to create an educational intervention that better meets the needs of that student. A functioning-based system truly is able to account for these differences by identifying relevant risk factors, social determinants of health, which is now in our kind of common vernacular now, and support factors that will help us through that intervention process. So the overall functioning of an individual may be described as the ability to carry out essential tasks and participate in daily life. And the ICF is a classification that provides a robust list of categories and a robust list of functionings that make sense. Functioning can be used to track the situation or status in general, but we can also use it over time. So we could, for example, do a baseline assessment using the ICF or ICF-based assessment instruments before an intervention or treatment. And then we could also capture it after the treatment as well to be able to determine how effective it is. The ICD-11, though, I would like to note, when we created the ICD-11, we actually pulled in some codes and categories related to functioning. We wanted to make sure that if some countries decided to just go with ICD-11 because they had already had legacy systems based on the previous versions of ICD, that they would have some ability to capture functioning information before they were able to accept and integrate the ICF. So we have some functioning codes and categories now within the ICD-11, and they are based on what's known as the WHO Disability Assessment Schedule. This is an instrument that's an assessment instrument based on the ICF that we pulled in, and helps facilitate users to determine a functioning score. So I just wanted to make sure that you are aware of that in terms of resources. In terms of the overview of the ICF, I want to move on. This is that red book, as I showed early on the presentation. This is a classification of health and functioning. It was designed to capture information about one's lived experience. So everything else, if you will, beyond the diagnosis that is captured in the ICD, we are able to capture here in the ICF. It's quite robust, and I'm going to go through a little bit on the next few slides about what is actually in this red book, okay? So much more versatile classification than a diagnostic system, as I already mentioned, like the ICD and the DSM. So the ICF, so some additional highlights. As the functioning and disability of an individual occurs, we know in a context, we also have to have that environmental context. The ICF provides this. When we built it and we were tasked with the idea of creating a functioning classification to work with the ICD, there were a number of individuals who were clinical professionals. Like myself, there were a number of other key stakeholders, like persons with disabilities, and we couldn't imagine creating a functioning classification without including the environment. So we worked very hard. We had an environmental task force, and we created a set of 5 kind of key categories of environmental factors. And then within those categories, like the built environment, for example, or support and relationships, we then go down level by level in terms of what would fall under those respective categories. But it was very important for us, and this actually was something that predates social determinants of health. We know later on, WHO convened in 2005 a commission on social determinants of health, and then later created a report a few years later, kind of building on some of the work I think that is reflected in the ICF. So the ICF provides a framework for measuring. Yes? Oh, Okay, provides a framework for measuring health and disability at both the individual and the population level. So if you're a clinical professional and just working with an individual caseload, you're able to use the ICF, you're able to use the instruments that are based on the ICF, but we can also use it at scale at country levels, population levels, to be able to capture trend data, information, statistical purposes, and so forth, to guide policy reform and so forth. So in 2001 is when it was officially endorsed by the World Health Assembly, and it has since become, over the 20 plus years, an international standard to describe and measure health and disability. The nice thing about the ICF, it is built like the other primary reference classifications on the same foundation. So they kind of share a lot of the same elements, and this is important when you're looking at comparability of health data. So the same foundation, ICD, EG, and ICF, they work together. And as a member of several of the WHO working groups, we often convene together in meetings remotely and then in person. We have meetings twice a year in person, where we're able to make sure there's what we call harmonization between the various classifications. And so they share the same, what we call extension codes, and this helps us enable documentation even at a higher level, which is often the case in clinical environments. We need to do that. More specific detail is needed. This is the framework, and this is very important. I utilize this in classrooms all the time to help just understand what, let's say, disability is, what health conditions really represent. So you'll see here on the top, the health condition could be anything, could be mental health condition, behavioral health condition. And you see how it interacts with a variety of things: bodily functions and structures, one, activities, and participation. And activities are all the things, like I mentioned, that we might do on a daily basis. Participation is a broader category that we created. So you might participate, let's say, in work. Well, that is comprised of many different activities to enable you to participate in work. So mobility might be one of those activities. Are you able to actually walk into your employment site, your workplace? Maybe even the transportation, right? Are you able to engage in transportation to get to the work site? Are you able to go from a standing position to a seated position? Are you able to sit for long periods of time if it's a sedentary job? Are you able to carry out those work tasks? Those are all activities that would comprise that idea of being able to engage in the workforce, and that would be a participation domain. We also, as you see on the bottom, have two kind of contextual sets of categories: environment and personal factors. So environmental factors, as I mentioned, we worked very hard in creating this part of the classification, because we know that a person's functioning level does not just happen. The environment is such an important aspect of that. So case in point, let's take our previous example of going to work. Well, if you walk to work on a daily basis, perhaps you realize you step outside and it's raining, right? So rain, weather, climate might be something that might affect your ability to get to work. If you perhaps don't have an umbrella or something to shield you from the rain, it might then cause you to make the decision, I have to wait a little bit till the rain stops. And when the rain ceases, then I'll go ahead and be able to walk to work. So you might call your work supervisor and say, I'm going to be a little bit late. I have to walk to work. I don't have a way because it's raining, perhaps very, very heavily, to get to work, and I'm going to wait. So that is what actually impacts your ability to participate and do that activity, rather than your ability, capacity, if you will, to be able to engage in that particular work. So environment can play a big role. And we know with health conditions, this is important. Certain types of, let's say, heat, excessive heat is problematic. Other types of temperatures are important. If you're needing a curb cut, if you understand what that is, a curb cut, if you're utilizing a wheelchair, you have to be able to get on and off of the pavement. If that's not available in your community, that will be problematic, and it will hinder your ability to be able to move from one place to another. So the environment is very important that we look at. Personal factors, as we know in social work, very, very relevant. We work on both of these things, and they comprise what's now known as social determinants of health. But the idea of race, culture, ethnicity, caste system, social economic status, gender identity, and upbringing, education, and so forth, all fall under personal factors. We know that also plays a very large role in terms of someone's health, someone's activities and participation. At the time we were creating the ICF classification, we made the decision to wait to build that part of the classification on personal factors. That was because it was a concession, if you will, it was just so labor intensive and time consuming to create the environmental section. We wanted to make sure that got in to the ICF. So we decided to hold
I'm
off.
sorry, Dr. Patricia.
Yes.
Sorry, I got feedback from the participant. Could you be slowly to explain
Sure,
the
of course,
PowerPoint?
of
Yeah.
course.
Thank
Thank you.
you.
So personal factors, we made concessions to wait to include those personal factors within the classification itself. So we have the classification that includes, and I will go over the list of body functions and structures, the activities and the participation, as well as the environmental factors. But personal factors are technically not included in the classification, but they're recognized, as you see here in the framework, as to be very important. And I will provide some information about how you can still capture the information because it is needed. Eventually, we hope to be able to update the classification to also include personal factors, but we do have assessment instruments that recognize and provide a mechanism to be able to reflect that when you're doing intake and assessment. Okay. Activities and participation, I mentioned that as these two things as critical and relevant components of the ICF. This slide shows that we have 9 major categories. You'll see here, we start off with learning and applying knowledge. So for those of you who work in the area of mental health, or maybe you work with persons with cognitive disabilities, you would be using probably that category quite often. We also have 2 general tasks and demands, 3 communication, 4 movement, 5 self-care, 6 domestic life areas, 7 interpersonal interactions, which is very important as we know in social work, 8 major life areas. So these are like kind of broad areas like going, education, going to school, 9 community, social, and civic life. So very, very robust and range of activities and participation. And each one of these are broken down into more specific categories, like self-care, for example. We could break that down. Many aspects are involved in self-care. Dressing, for example, is one, eating, drinking, and so forth. And then you would break it down into even further detail as needed clinically. I mentioned the section on the environment. There are 5 main categories within this particular domain. Products and technology are one. So if you have a client that you're working with who utilizes a cane, for example, for walking, or an augmentative communication device, it would fall and could be classified and coded under the number 1. Number 2 is the natural environment and human-made changes to the environment. This is very important when we're working with persons with disabilities, but all persons as a social worker. It's very relevant. 3, support and relationships, very key. Does that individual client that you're working with, do they have a family? Do they have a support network to help them, perhaps, if you're looking at medication compliance? Are they having someone there to help them, remind them, get the medication? For example, if you're working with someone who is an older adult with the beginning stages of dementia, this could be something very relevant. And I know Pooji had mentioned about the care economy. If you have someone within that household to provide that support necessary to help them with their functioning, you may not need to outsource it and have someone be paid to actually do those tasks. So very, very important. Attitudes, as we know, are essential. And then services, systems, and policies as well. And that's the 5 main categories within the environmental section. As I mentioned, personal factors are recognized in the framework that I showed you, but not technically coded within the classification. Some of the variables that are very relevant, I mentioned already, but age, race, gender, education, social background, psychological assets, lifestyle habits, upbringing, and so forth. And this is what, together with the environment, comprise contextual factors and allows for the recognition of what is now known as social determinants of health. So this is where you would capture it within the ICF system. The third classification that I want to just provide a brief overview is the ICHI system. This is the newest classification. It was driven by the delegation out of Australia, and it's becoming a common tool for reporting and analyzing health interventions for both clinical and statistical purposes. Within the ICHI, there are interventions carried out by a broad range of providers, including social workers, which is wonderful. So it really addresses the full scope of health systems and social systems, including interventions on diagnostic, medical, surgical procedures, mental health is in there, primary care, allied health, functioning support, rehabilitation, traditional medicine, and public health. So very broad in terms of the disciplines, the sectors, and the providers that would be part of this kind of continuum of health and social care systems. How it works is that it's built around 3 axes. So we have a target, which is where the action, whatever that might be, would be carried out. The action itself. So what are we doing? Are we doing some sort of intervention, for example, or treatment? And then what is the specific means, the process and methods by which the action is carried out? So is it a intervention in terms of a therapeutic intervention, like a particular type of therapy? Are we looking at medication treatment as the means? So it provides us a specific way that we can capture this information. And as I already mentioned, the ICD, ICF, and ICHI share the same foundation level. We have what's called extension codes where we're able to make them work with one another. And if we need to add, and that's what extension codes are, add some additional detail, we are able to do it, but it still connects them, right, to one another. So that's key. So it's a kind of we have a simple, what they call logical syntax system that links this ICHI STEM codes, which is the basic codes, and extension codes, and makes the system work one another. And we're able to actually then link, because we know often when we work with our clients, we're doing more than one intervention, or we have different actions that might comprise that intervention. We can actually link them together in a package, which is nice. So some of this might matter more if you're interested in the data side of it and the health interoperability side. But clinically, the important thing is that we're able to capture this high level of data for all types of clinical documentation. So I think that is probably more relevant to those who are attending today. So all in all, using this package system of health classifications allows healthcare and social care providers to convey results of their specific and specialized professional assessments in universally understandable terms. It also helps to support clinical judgment related to the evaluation of a particular client in a particular context, because we can bring in that environmental information, bring in the personal factors and context as well. And it's very useful in helping us monitor treatment and intervention goals and outcomes, which is what in social work, as we know, is essential for our jobs. I want to highlight this particular slide. This is what's known as the HUFIC maintenance platform. And I speak to clinical providers and professionals around the world. And I mentioned that the classifications were created with input from clinicians. And we still need clinicians to give us input. So you're able to actually go online. You can register for free and you can see the maintenance platform. This is important if you would like to provide or submit a proposal. If there is something, for example, and this is important for cultural context and country context, something that perhaps doesn't make sense. It could be a specific code, it could be the phrasing, it could be the relationships of codes, something that is missing within our classification. There's a number of reasons why people submit a proposal and a request for our team to look at. So I would encourage those on the call and others with Indonesia to be able to take a look at these classifications and provide the feedback in this formal way so that it is made as a point of documentation and it can come to our working groups so we may consider changes to the classification. So it is definitely a dynamic process and we're constantly updating, as you know, and every year we do annual updates as well. So it isn't just about the versions like the ICD-10 moving to 11, but we provide annual updates where we're able to pull in things. For example, more recently, we were able to update the ICD to make sure it reflects rare diseases, which is very important. So that's just one more recent change that we were able to make. So I do encourage everyone to take a look and see if this could be useful to you and to help us improve the classifications. So in terms of our viewpoint as a social worker, we know that the medical model and even the social model are not sufficient to address functioning and disability of individuals. In social work, we know the strengths-based perspective is very much at our foundation in terms of our profession. And so we have moved to include and embrace in the ICF the biopsychosocial approach. We use ecological and systems approaches like person and environment, which is inherent in the ICF framework and classification, but also as a system overall. Being to understand that there's a place for the ICD, for the ICF, and the ECHI systems, all within the same ecological ecosystem, if you will. So it's important that we have this reflected and it's built in because it aligns with social work practice, right, across clinical and other settings, and also enables us to work with other professionals. Excuse me, I'm going to take a quick drink if you don't mind. Okay. We know that we work with those other professionals often on interdisciplinary teams, and there is value by having a common language, a common terminology and classification to share between one discipline and another. So the ICF is considered a common global framework for organizing this information around health and human functioning. As already mentioned, it includes both mental and physical conditions, and it allows us to communicate information because it is so broad and robust across clinical professions and other sectors. There are a number of clinical professional organizations outside of social work that have adopted and integrated the ICF within their scopes of practice. And this includes occupational therapists, physical therapists, speech language pathologists and audiologists, recreational therapists, nursing, and so forth. Social work, ironically, although we focus on functioning and the environment, we have not yet at a global scale, certainly, but certainly within countries, have integrated the ICF into our scopes of practice. So this is something that I recommend often when I speak to social workers, that we need to be able to come together and be able to do this. Very, very essential. Social workers, we know, practice in diverse settings with other professionals, part of a care team. So utilizing, as I already mentioned, I'll reiterate, a common language and system, like what I have just presented this morning, is very beneficial for information sharing and promoting collaboration. It's like language, any kind of language, right? So in Indonesia, you have your language that you speak, and other countries, we have different languages. But being able to share that ability to communicate with a single language is very essential, right? As we know, for moving us forward and being able to collaborate. So utilizing this and treating it as a language is really important, that we integrate it within other countries because other countries are already using it. And we also know that we conduct regularly assessments, interventions, we evaluate. And so having tools that are based on the ICF, I mentioned that HUDAS instrument, for example, which is the WHO Disability Assessment Schedule, and other assessments which have been crosswalked to the ICF are important resources to share. So now I'm going to move into some of these projects that I'm involved with and resources that could be helpful to you as you consider integrating and utilizing the WHO health classifications to be able to promote the value of social work in the healthcare space. This particular project is called the PASIO project. The PASIO is an acronym for Post-Acute Care Interoperability. You see that here at the top slide. This was a poster that I presented at a conference on behalf of our team, and you'll see the people listed up at the top. The PASIO project is a project that is sponsored in the United States by the Centers for Medicare and Medicaid Services. Medicare beneficiaries represent about 45% of those that are going into post-acute care services. And we know post-acute care is something that is a commonplace after discharge from hospitals, like skilled nursing facilities, for example, is one of those locations. But in the United States and globally, we know there's a disconnect in how we transmit information from one setting to another. And so we created this PASIO project in 2019 it's being led by a corporation called MITRE. And the charge that was given to us was to establish a framework and create implementation guides that could be used by electronic health record vendors to build their systems and facilitate information. So we wanted that in the spirit of those international classifications, we wanted to be able to have a single language and approach, and we call it FIRE, to be able to have all those vendors be able to communicate with one another, regardless of where they're setting, regardless of the hospital setting, the city that they're situated in, the post-acute care facility, and so forth. And FIRE is another acronym. There's a lot of acronyms here, and I try to put them on the slide, and I apologize because it is a lot and could be confusing. But FIRE stands for Fast Healthcare Interoperability Resources. FIRE works with what's known as HL7, which is the Global Health Level 7 standard for electronic health information. And so we're creating these implementation guides and making recommendations for FIRE to adopt, okay? And then and it is working through the process already. For example, functioning information you see here toward the other part of the slide, it's in a purple color, says personal function engagement. These are our kind of work streams and use cases. And so we have already put forward the recommendation to bring in personal functioning information into electronic health records and to use the ICF as the classification and terminology for that. So there's others, as you see here, advanced directives in the kind of green color, yellow is transition of care, and the pink is standardized medication profile. We have work groups working on all three. I work primarily in the personal functioning and engagement group, but what we're basically enabling and helping technology now capture this information. So it's pretty amazing. We have clinical professionals and others that are part of this. And toward the bottom, you see we've been able to map the ICF to core areas related to personal functioning, and we've been able to pull it into the system, and we've been able to test it through what's known as Connect-a-thon. So we know it actually works. And so what does this mean? It means, so if we have a client, for example, if you're a hospital social worker, you're working with that client in that particular context, that client gets discharged, maybe they go home, maybe they go to a nursing care facility, maybe they go to a rehabilitation facility. We're able to then pull that information from one place to another place to another place, and we're able to capture through those functional assessment that information, pull it into the electronic health record. So this is really going to streamline the process. It's going to increase and enhance communication between settings and between interpersonal and interprofessional team members, and it's going to help improve health outcomes. So it's pretty amazing. It's been more than 5 years at this point working with this group, but as you know, building the classification, well over 20 years, being able to show that it actually is relevant. I'm going to move to the next slide here, if I can. I don't know why it's not moving. Let's see here. There we go. Some additional examples, and these are posters that I pulled from various sources. I think that these next 3 posters are from the WHO Family of International Classification meeting. We have an annual meeting, as I mentioned. I just pulled examples of things that I've been able to report on as part of some of my working groups and also from just my own research and scholarship and professional work. I wanted to provide this, and if you would like the actual poster outside of the slides, I'm happy to also share that with you. So that way you can perhaps increase the size and so forth. But this is a poster that provides an overview of a project that we did through the ReLab Rehabilitation Lab, which is situated at Johns Hopkins University in the United States. And I worked with a company called Physiopedia. It's actually a registered charity out of the UK. They have a series of courses, and they're one of the largest rehab providers of continuing education in the world. And so we created a series of courses around the ICF. So if you're interested, you can go to their website, you could register, and you can, I think, take several courses for free. They are also offered at a discount for students and also on a sliding scale based on your country of residence. But there are, so the ICF, if you want more instruction and detail, you can go there. But you'll see here, this slide just kind of gives an overview of what is actually available through the series, and there's 5 courses related to the ICF. This paper, this poster was presented at the HUFIC meeting in Barcelona, Spain, well over 10 years now. And so just kind of gives you an idea of how long I've been, even before I presented on this, I integrated the ICF into various social work courses at my university. And this shows you how I did it, how it was useful to talk about and educate up and coming social workers on the ICF, how I was able to incorporate certain things and what they were in terms of the checklist, which I can share with you also, which is a form that basically helps you do an intake and a brief assessment utilizing the ICF categories when you're working with clients. And then just gives you some detail on how we were able to evaluate the program. This next slide, it talks about how we were able to create an interprofessional clinical training program. So outside of the classroom, we actually have a pro bono, which is a free clinic on our university campus. It's primarily led by students in physical or physiotherapy, but we've been able to pull in students from social work and dietetics and nursing. And we then have those clients and we work as team, and it provides kind of a more real world experience, if you will, for our students across different levels, undergraduate, graduate, and doctoral level students, to be able to engage and work with real clients. And so this describes how we're able to integrate it. We also have what's called grand rounds. So if you're in medical school, this is very common. So we've adopted that same practice because we are within medical and health professions and contextual settings. So we provide patient cases, and the students then go around and they discuss, if they're the physical therapy students, they discuss what they did and what they found through their assessment and how they created the intervention, what that was, and what the outcomes were. Social workers then would come next and they would talk about when they did their respective assessment, what they were able to find, what were those social needs and the resources that they were able to refer that client out to, and so forth and so forth. So it's a model that we were able to adapt for use in our clinical environment. So that I wanted to share with you today. And I think this might be the last example. So this is a five-year interprofessional training program that I did actually in Hawaii. So if you're familiar with Hawaii, such a beautiful climate, and like in Indonesia, like you have, and beaches and so forth. And so I was able to do this for 5 years. Conduct a series of trainings each year with a very multidisciplinary and multifaceted audience coming from all over the world. And so this describes what I did in terms of that training and providing case examples and having attendees have an opportunity to actually code and learn about it, which was very useful. So I wanted to share this information with you. I also have educational materials that accompany this. So if you're interested, I can make those available. So as I end the presentation, I know we're at time now, we're going to go into Q&A. I wanted to end with this slide that I think really my work, what I do, and I think so many of you in this room also, is to help people see the ability, not the disability. And you see here on the slide, you have someone who we assume that they are not able to see. They're using a cane and they have a dog, which is for their support and assistance. But they're thinking about in the shadow, right? Maybe this is them previously, or maybe they're thinking this is what they would like to do, but they're playing a musical instrument. So we can never just judge someone and assume that they cannot do something. We need to ask what they're interested in doing and see if we can help them achieve those goals. So I wanted to end with this particular slide. I hope you enjoyed it. And these are ways to keep in touch, and please do keep in touch with me. It doesn't matter if you're a student, a faculty member, someone from the general community and public. Please follow me on LinkedIn. You can message me through the LinkedIn system, also through Instagram if you're interested. And there is my email that you can contact me if this is easier. I will always like to give several different ways. So you can, if you prefer a particular way, you can contact me if you would like some clarification or some different materials. So thank you again for having me today. I hope I did provide information that can be useful to you as you move in showing the value of social work within healthcare within Indonesia. So thank you so much.
Thank you, Dr. Patricia. I have already followed you in the LinkedIn and Instagram. Okay.
Thank
Very
you.
interesting and insightful presentation. You provide many publication and links. It really helped for us. And Dr. Patricia explored how classification system like ICD, ICF, and ICHI can support greater inclusion of social workers into the global healthcare ecosystem. So, while waiting the Q&A session, we will listen to a welcome remark from the chairperson of the Indonesian Association of Medical Social Work to Miss Firolia. Are you with us?
Yes.
Okay,
Hello, good
please.
afternoon, everyone.
Afternoon.
Afternoon.
Is it audible, Kak?
Yes,
Yeah.
I believe.
So can I start?
Yes, please.
Okay, thank you. Thank you so much once again. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and maybe good morning for Dr. Patricia, the Honorable Dr. Patricia, Mr. Puji Pujiono, all the respected organizer, colleagues, and also all the participants who were really excited to learn tonight. So allow me to introduce myself. My name is Virolia, and I have the honor of serving as the chairman of Indonesian Medical Social Workers Association here, and it is truly a pleasure to welcome Dr. Patricia once again. So I had a privilege meeting her during a previous conference in Jakarta. So nice to meet you again, Dr. Patricia, and we're really grateful to reconnect again with you today in this meaningful forum. And also, let me begin by expressing our deepest appreciation for your insightful and also inspiring presentations. We also thanks for IPSPI for convening this essential dialogue and also continuing to create a space for us to connect learning and also uh, have a progress for our better medical social worker in Indonesia. So let me start by a quote that said, "What gets measured gets valued." Jadi apa yang bisa diukur biasanya akan lebih mudah dihargai. So yet, in many of our hospitals, the work of medical social worker remains largely invisible. Not only it lacks substance, but because it lacks of institutional recognitions. So there is no coding, no classification, and often no space in billing system in our national insurance called BPJS. So, Dr. Patricia, your words have not only illuminated the essential values of person-centered care and also evolving role of medical social worker globally, but also it feels like a time to reflect on how far we still need to go as a medical social worker in Indonesia. And also your explanation about the ICD and all the classification system was especially useful and also applicable here. So it gives us a clear understanding of how we can position our medical social work within the existing health frameworks. So we sincerely hope that in the near future, maybe we can begin to adapt and also apply this international system in Indonesian's healthcare context so that we can work can be so the medical social works can be better recorded, recognized, and also integrated in our healthcare system in Indonesia. And maybe just a little bit informations. In Indonesia, we have 70 medical social workers, including, I'm so sorry, 70 medical social workers and also 13 newly assigned professionals. So we already have 83 medical social workers in Indonesia across 27 hospitals in Indonesia. Well, this is a promising start, but it is also far from enough, I know. But according to the Ministry of Health of Indonesia, we still need at least 600 medical social workers in the future to meet the growing demands of holistic and also integrated healthcare. So hopefully we can achieve that target. So once again, today's session is really, really important. And I think it is not just a knowledge sharing event, but also a moment for us to rethink, reframe us, or rebuild our system in Indonesia. Hopefully, we can do collaboration in the near future. And also, we want to appreciate and also we are also truly encouraged by your ongoing commitment, Dr. Patricia, to advancing our professions. Your effort, especially in the developing of medical social work development centers. I have the information about it, and it is really incredible and awesome how you offer a valuable model of for how academic, professional, and also in the institutional collaboration can drive real change. So, on behalf of Indonesian Medical Social Workers Associations, maybe I want to reaffirm our readiness to partner, to learn, and also to co-create. We're really eager to collaborate internationally and also to align more closely with the global standards, not only to strengthen our professions, but maybe also to ensure that more equitable and also effective care for every person that we serve. So hopefully we really can achieve the holistic care system and also help people to help themselves. So once again, let's today mark the beginning of stronger partnership and share momentum for the future medical social worker locally and also globally. And thank you so much once again, Dr. Patricia, and all the participants who really, really excited. I know that some of my colleagues already asked for some questions for you and really want to discuss more about our practice in Indonesia. So maybe that's all that I want to say. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Miss Virolia, for your remarks and your explanation about medical social worker in Indonesia. And this framework is very helpful for medical social worker in Indonesia. Okay. Okay, now we enter the Q&A session. Please type your question in the chat box, or if you want to give question directly, please give your hand, raise hand. Anyone to ask Dr. Patricia? Okay, I will read before.
Ibu
Okay.
Mary, excuse me, we
Yeah.
have two participants raise their hands.
Oh yeah.
There are Ibu Ina Ramirajani and Ibu Zakiatul Mawaddah, while the others are giving a written question in the chat box.
Okay, we will give the change for Miss Inara for ask question directly to Dr. Patricia, please.
All right. Thank you very much for the opportunity, ma'am. My name is Dinara Mirajani, and I'm an undergrad in UNPAD Social Welfare Program. My question for Dr. Patricia would be regarding I'm very sorry if I'm a bit rambling, as I have quite the ADHD mindset here, but it would be regarding, as mentioned previously, our ability to communicate between fields. I really do feel like the different languages, as you say, across the fields have a tendency to make our collaboration a bit jilted, or that we don't see each other in the same, like eye to eye. Yesterday, when I was doing my internship in what is yayasan? My apologies. A social institute, I think. We tried to work with our local clinics, and it seems that the paradigm that we have, which is more empowering and seeing humans as themselves, would not be shared as much, or is not the same degree as the materialism that most doctors and medical workers have. But then again, I could also say that social workers and their view of empowerment and sense of idealism has a chance to be manifesting into toxic positivity. So they don't see that instead of like addressing the issues, they have a tendency to just cover it up with like, oh, here are the things that you can do, well, without addressing the negative aspects of the disability or the health issues that the patient has. In that regards, what would you say is the best way to bridge the gap, and what do you think is a good balance? How do you balance between these two paradigms within these fields, I would say? Thank you.
Sure. Thank you for your insightful question. And I think you're right on point. You didn't ramble. You, I think, summarized very nicely that we have this dichotomy, right? And within the healthcare system, it's very important to address. We have to be able to figure out how we're going to come together. And I think it's changing. So certainly we're seeing this. Maybe it's driven by certain countries, but we are seeing medical doctors, for example, coming away from that medical model. Where, as I mentioned in my presentation, we have the recognition of social determinants of health. And so what is happening is, there has to be a reason, right, why there's a change. And so, and it's not enough that someone comes and does a presentation and says, you really need to do this. We have to show evidence. And often we have to show it in terms of financial savings and so forth. So, because money talks, as they say, is a very common phrase, right, worldwide. So we're seeing this in hospitals, we're seeing this in healthcare systems, that they're not achieving the health outcomes that they want. And so they have stepped back and evaluated why this is the case. And they have found that really some of the missing parts of the puzzle, if you will, is the fact that we don't take into account social determinants of health. And also, they realize that some of the costs that are generated in hospitals could be avoided, right? We could reduce readmission rates. We already have evidence that says if you bring in social work and we address social determinants of health, which is what we often do, we can save money to that healthcare system. So I think just changing the conversation is going to be helpful, but we have to meet people where they're at, other professionals where they're at. We have to talk their language. So for a lot of hospital administrators, it's what they call dollars and cents. It's the money. It's the efficiency of the hospital system. It's improved healthcare outcomes. So these are the things that we have to be able to use, the metrics that, as Pooji said in the beginning, performance indicators that we need to be able to convey the value of social work. We need the quantitative, but we also need the qualitative. And so we know this all the time. I was just on another conversation yesterday. We're putting together a grant. What we want to do is we want to test a new model in healthcare, where instead of, when you come into the hospital setting, right, you get triaged and so forth, and there is a general intake if you're not an emergency room level admitted patient. But if you go in and you do an intake, and then you get usually sent out to someone who can do primary care, for example. But wouldn't it be great if one of the first people that our patients see are social workers? So rather than waiting for this entire process to go through at a hospital intake session and perhaps admitting the particular patient and then referring out to social work, why not have the social work be one of the first professionals of contact and have social workers do their comprehensive social assessment, biopsychosocial assessment, to determine, is this patient here because there is a medical need, or is this patient here because there is a need that is a social need, a non-medical need? And this happens all the time. And so the idea that we came up with is can we pilot test this out and see, and then quantify the savings that it would be, quantify the cases where it actually isn't a matter of a health need, but we could avoid unnecessary tests and the costly procedures that they have to do once that person gets admitted into the hospital. So, but I think it's, to your question, and thank you again for it, is being able to develop a better way of communicating the value of social work across disciplines, but to understand those other areas, the medical doctors, for example, the hospital administrators, the business people, the CFOs within hospital systems, to be able to understand what's important to them and make sure that we can provide that data that is needed for them to understand our profession. So I hope I answered your question. Thank you so much again.
Oh, yes, very much so. Thank you. May I ask if it's okay to ask questions through your IG as well?
Yes, of course, please.
All right. Thank you very much, Doc.
You're welcome.
Okay. Is the explanation clear, Miss Inara?
Yes, ma'am. Thank you.
Yeah. Okay, we will move to the second one. Zakiatul Mawada, please to open your microphone.
Okay. Thank you, Miss, for the opportunity. And also, I'd like to say thank you to Dr. Patricia for the presentations. It's very, very helpful for me as a new employee and medical social worker, especially in Indonesia. Before that, I'd like to introduce myself. My name is Zakia, one of the new medical social worker in Indonesia, especially in West Sumatra. And during my first month as a medical social worker, especially in installations of medical rehabilitations, to be honest, I have a lot of questions in that running in my head, whether it coming from myself as an individuals or professionals, and also coming from my colleagues and the medical team and my hospital, that I can conclude that okay, I will not go into the specific issues that I met in my hospital, because I have been running as a medical social worker only a month, but I can see I could say the general issues that happen in developing countries, especially in Indonesia. There is a economic problem that the problem is strongly connected and give a big impact with the society that have a problem in healthcare. And what I've met the problem in my hospital is a lot of not only the society, not only the patients, but also the medical team sees that a social worker as a financial providing or just a financial or material providing. But maybe it not comes to medical social worker, but also the social worker itself, whether in Ministry of Social or also Ministry of Health Care in Indonesia. So I would like to deliver questions. How we as a medical social worker can strengthen our positions and bring our values and our framework as medical social worker, but also can deeply present with our main problem, that is economic problem. So we could bring our values not only to providing, but also to help people to help themselves, to help people to developing with their current situations, and also how we can apply or implement ICF indicators to developing countries, especially in Indonesia. Could you please give me a specific case or a specific conditions that I could implement in my hospital? And also, I strongly think that also my colleagues as medical social worker has a especially the beginners medical social worker has the same problem. So I would love to get um, your yeah advice to me and to my friend as a beginners. Thank you.
Sure.
Okay,
Thank you
thank
so
you.
much for your questions and also for the information. It was very good for you to provide the context to help me understand what is going on. And congratulations on being one of the social workers here in Indonesia. It's a start, and it's because of people like you that you're building the legacy within your country. And I hope to come back to Indonesia and there will be 100 social workers, right? And then I want to come back again and you have even more social workers in line with what you need to support the social needs within your country. So thank you again for that. There are a lot of resources that I have access to, and I'm happy to share them with you. I put a few through the chat. One of those is the ICF checklist. This is an assessment-based instrument on the ICF. The ICF is a classification, so it's not an assessment. So it's a list of categories and codes. And if you go online to WHO website, there is a browser that's electronic, so you can type things in and like keywords, for example, and you can get the relevant code. But the checklist is a multi-page document that will allow you to, in your actual hospital setting, start to document what is going on. And it's things that I would assume you're already doing. You're using some sort of functional assessment or some mechanism to document what that particular patient needs. But what it does is then you can then look at what are the relevant categories and you can see the actual ICF codes. So it's a nice instrument, and it also asks you some other questions. It enables you to capture the personal information and the personal factors that you might find that are relevant in working with that particular individual and that particular patient. So I would recommend utilizing perhaps that. There is also the HUDAS instrument that I mentioned, which has a kind of short list and it has a longer, more composite list of questions that you could ask. And it is an instrument that you could do as a social worker, but you could also have individuals, respondents, the patients themselves complete it. So these are all very good resources for how you can actually implement it in actual healthcare. I have a current project that's been funded for the past 3 years. We have built a series of training modules for social workers. And it is more, one of the modules is more clinically focused and how we can actually utilize the instruments and why they're needed in healthcare settings like hospitals and so forth. So we are finishing up that project. I have a co-PI, Lucinda Jones, who is a social worker who works at the Veterans Affairs VA in the United States, which is one of the largest health providers of social workers in the country. And so she and I have been working on this because we saw a need for social work in the United States and outside of the United States to be more clinically trained on utilizing it. To your question of how would I actually use it? So we provide real examples. So if you're in a hospital setting, this is how you can incorporate this and this instrument and walk you through that. And we tried to be very culturally relevant. We have diversity reflected in this as well. So once these are finalized, I will be happy to share that with the organizers here. And if you're following me, obviously on LinkedIn or something, I'll probably put something because I'll be so excited when we're finally done after 3 years of production. I will put it on there and make that available. So please keep in touch with me. I hope I answered your question, but there's probably more specifics that you need, and I'm happy to provide some additional instruments, additional information to help you implement this in Indonesia.
Okay, thank
Okay,
you.
thank
Is
you,
it
Dr.
enough?
Patricia. Yeah, thank you for the explanations. I will wait for the upcoming answers and upcoming learn that I could take and I could implement soon in my hospital and also with my friends. And it would be nice, and I'd love to learn for you with another aspect of a medical social worker if you if you
Sure.
want to. Okay, yeah, that's all for me. Thank you.
You're welcome.
Okay, thank you. The last one from Rosie Karuniawati, please to us directly.
Yes, thank you very much for this opportunity. Could you hear my voice clearly, Miss?
Yes.
Yeah, clear.
Okay. Thank you. Before that, let me introduce myself, Dr. Patricia. I'm Nia, one of medical social worker in Indonesia. I would like to tell you about how I and my colleagues struggling in our first job as a beginner medical social worker, and also we're the first one in here. So currently, my
I'm sorry, your voice is not clear. Sorry, Miss Rosie, can you hear? Okay, maybe some trouble from Miss Rosie. Anyone to ask directly to Dr. Patricia?
Ibu Mary, excuse me, I think we lost Miss Nia. Maybe there are some connection issue. Maybe we can continue to another questions.
Okay, okay. There are three questions from the chat box. The first from Ananda Bagus. Hi Patricia, I'm Ananda Bagus Satria Ganesha, but please call me Bagus. Thank you for your insightful session. You have shared to me well in the Indonesian healthcare context. The presence of professional social workers remain limited, with patient support in hospitals still largely provided by family members. Given the growing recognition of holistic and psychosocial care, what are the existing regulation framework governing social workers in the healthcare sector in the United States? And which component of this framework could be appropriately adapted for implementation in Indonesia? Maybe please answer, Dr. Patricia.
Sure, I think I heard it correctly. The person is asking the question, interested in the regulation around social workers, okay, in the United States and so forth. Okay, so we have a variety of regulations. So there's not just one. We're supposed there's such a large healthcare system, and often, so we have federal legislation that regulates, like something like HIPAA, for example, with, we're protecting health information. So all healthcare systems must follow, all healthcare providers must follow this and protect healthcare information. It's confidential and so forth, and how we store it and everything's heavily regulated. We also have, if you are a Medicare or Medicaid provider, that's Centers for Medicare and Medicaid, which I mentioned with the PASIA project, they regulate, they provide specifics on how if you have a Medicare facility, what you need to follow. So there's regulations on that end. Of course, we have regulations within actual healthcare systems. So United States, we don't have this global, single country healthcare system. We have multiple players. So it becomes very complex. So within that healthcare system, they have their own regulations, right? They have to follow. So to answer your question, in a short response is that it's very heavily regulated, very complex. So I can't tell you exactly one particular thing that's problematic, but or one particular thing that is effective. And so this is hence problematic to answer your question. But I will say that, we have an entity called the National Academies and the National Academies of Sciences, Engineering, and Medicine that provides a lot of guidance to everyone within our country. So if you are a healthcare system provider, you might look to, we call NASEM is the acronym, for some information about how do we then make changes, let's say, to healthcare systems. So I was fortunate to be a speaker a few weeks ago on a talk about looking at how we can improve mental health services and across the board within our country. And I did mention social work. Specifically, I was in the group for workforce training and the workforce pipeline. And I mentioned how we need to have social workers involved in health and mental health care settings. I talked about our training because I think many different healthcare systems, they don't understand the rigorous training that we have for social work. And I think this is global. Certainly in the United States, we use competency-based training. We have many hours of actual practicum, real world experience. And if you're doing clinical work, you have to be licensed in the United States. So those are all regulations that are instrumental. So I think I wanted to address your question in my response from that angle as well, that I think social work as a profession, we do such an amazing job regulating our profession. We need to be able to convey that so we can ensure when we think about the value of social work in healthcare, that when you hire a social work, they are properly trained. They are trained well to know the situation. They are trained to do their job at hand. So I think that is something I think is very important when you're looking to, and I know you have these things that you're already doing, you've integrated in your program, but as you're developing and you're trying to expand more medical social workers to understand, is it, do we have supplemental training in the form, let's say, of a certificate to supplement what you're getting in terms of your schools and programs of social work? However you want to do it is fine, but I think that is one of the hallmarks, I think, is it's something that differentiates us from some other professions, is that regulation around credentialing and training that we have for social work. So I hope that answers your question in part. You can follow up with me more if you were looking at specific types of legislation or regulations. I'm happy to share that with you, but there's a lot of them. So thank you again for that question.
Okay, thank you. Dr. Patricia, is it clear?
Yes.
Aninda bagus? Okay. Okay.
Yes, thank you, Miss.
Okay. Thank you. Miss Rosie is back with us. Hello?
Oh, yes. Yes, ma'am. I'm here. I'm
Could you
sorry, I
please-
lost my connection.
Yeah, could
Yeah.
you please repeat your question?
Okay. So Dr. Patricia, like I said first, I would like to tell you about how I and my colleagues struggling in our first job as a beginner medical social worker, and also we're the first one in here. Currently, my college and I are facing a dilemma at our hospital. We're having difficulty practicing our profession because the hospital management system has placed us in another unit that has no relevancy with our profession. So the unit we're in is in the front desk where we register patient. So I would like to ask you about, based on the situation, could you give us advice, advocate cognition from hospital, or are there who WHO toolkits or guide can
Sorry. Miss Rosie, you lost your connection again?
I'm sorry, I lost.
Okay, maybe you can to ask the question. Okay,
Yes, maybe I can.
Okay, maybe you can add. And maybe Dr. Patricia get the question?
I think the question was the difficulty because there are, just starting out here in Indonesia, integrating social workers into hospital settings, some advice, right? On how we can address the challenges of being more recognized and more situated, because I think the individual had mentioned being placed in a different unit and so forth. So I think, it's going to take some probably efforts, right, on your part, and then others. I think raising awareness of the value of social work, but also the experience as you go through and be able to show your value, I think is going to be absolutely essential. We know there's been several steps, whether integrating in the United States in our healthcare systems and our hospitals or other countries, you need to secure that buy-in from your hospital administrators. So, you can use best practices, you can mention how other countries really value and integrate social workers. And as I mentioned, the return on value, right? The return on investment. And I am happy to share some of that information. There is actually someone, a social worker who has an MBA. Her name is Christina Rodriguez. She and I serve on a coalition for social work and health, which is situated in the United States. Christina, a very proud social worker, but with her financial MBA business background and additional degree, she has been able to really quantify some of this stuff. And she has a podcast called the Outcomes Podcast, and she has other resources. So she is on LinkedIn, and I can provide perhaps a link, if you will, to her page in LinkedIn. But she and I have had many conversations about how we need to reframe the conversation and be able to show, she was able to show most recently, I read, maybe even last night it was, that, she said something like her salary annual was, when she was in the hospital ER, she was making 30,000 equivalent US dollars, but she showed how that hospital in one night made more than $30,000. So in one night, that hospital, and she breaks it down into the costs. So she does things like that I think adds a lot of value to the conversation and to the justification of why we need social workers. I think also, besides securing the buy-in from hospital and healthcare administrators, you need to establish your clear roles and responsibilities. What are you doing that is different than what other people are doing in that particular setting? So making sure that's very clear so you can justify and then you can quantify in terms of the value. You also need to, and I mentioned about how the ICF and the whole system enables interprofessional collaboration. I think you need to do that as well. Make sure you're talking to other clinical professionals. I do it a lot. I do it not only clinical professionals, but I talk to a lot of people outside of the field and the clinical field. Like I mentioned, business people and economists and so forth, because I think it's important that they understand what we do, right? So I think that's key, and to find the people who can help champion social work. And then finally, if you will, I would say, to focus on how social workers, our domain is social determinants of health. Social determinants of health is something you can go on WHO and you can Google and search for the documents related to it. It is something that we're promoting globally as important, as essential that we address. And if we do this properly, we will be able to show better health outcomes. And for those cases where hospitals and healthcare systems have already addressed this, and have brought in more social workers, have integrated social workers on those teams as key personnel, and say that they are doing this, they're addressing social determinants of health, we are able to have better health outcomes. We are able to discharge our patients sooner. We're able to reduce the hospital readmissions and overall enhance the healthcare experience. So those are things that I would recommend. It's a lot. And so, please follow up with me if you need some additional advice or specific information on how to do this. But I wish you well. You have a very important role, and you're a pathfinder, if you will. You're leading the way within your country.
Okay, thank you, Dr. Patricia.
Welcome.
Because we have limited time, so maybe it's enough for Miss Rosie. Yeah. Okay, we are going to next question from Miss Hastin Trustisari. Considering the social workers' viewpoint that emphasize ecological and system approach, how does ICHI accommodate such approach within its intervention classification, especially in community or non-clinical setting?
Okay, so can you repeat the question? The question is about the health intervention classification?
Yeah. How does ICHI accommodate such approach within intervention classification, especially in community or non-clinical setting?
Okay, so the health classification, as I mentioned, is the newest one. It works with the ICD for diagnosis and works with the functioning-based classification where we're able to also capture the environment. It's a very robust classification across the health system. So it will actually move you into the community setting as well. So some of the things like allied health, rehabilitation, public health, maybe traditional medicine. These are things that we would see more likely out of a hospital setting, but in the community. So it does classify that. So if you go online, and I can put the link directly into the chat, if you go online, you can then browse. There's a blue button that says ICHI or ICHI online, and you're able to click on that. And then once you click on it, you can then search by keywords. You could also, it's drop down boxes. So you can go to the category of the ICHI category and you can look at health interventions and you can click on the various health interventions that you're interested in. As I mentioned in my talk, there are 3 primary components or axes within the ICHI system. There's the action, like, is it a diagnostic action? But for us, to answer your question, you would probably move away from like diagnostic, and it might be therapeutic. It could be managing. There's an action called managing that's very social work oriented. And with that enables us to classify and code to document advocacy, planning, navigating, collaborating, and so forth. So this is wonderful when we think about social work. So now we have an ability, once this is being pulled into electronic health records and digital health systems, to say, and this goes to probably some of the other questions that were asked today, how do we actually make this work, right, in our healthcare system in Indonesia, is that sometimes the answer to us when we make the request is that, well, we don't have the system set up. Like I used to hear this a lot. We don't have the technology to allow us to bring functional information into our case record, even though we recognize it's important. Now the technology is here. So with that said, we have now a new classification and we have the technology that recognizes the ICHI as an official classification and terminology for digital health applications and for electronic health records. And in it has social work interventions. So now that we won't be able to hear, we can't make this happen because it's there. So that would be something also, as they say, as a convincing point for your purpose. You can say, well, with the WHO classifications, besides the ICD, we have the ICF, but we also have the ICHI, and the ICHI does recognize social work in it. It recognizes those health interventions that social workers utilize in their day-to-day activities. So I will say that, and feel free, please, come back to me and follow up. And I'm happy to, even if you would like me to schedule a Zoom one-on-one to walk you through the classification, or if others, now I'm offering this up. So we're going to have to do a subsequent workshop now where I can actually go online, and I'm happy to walk participants through these classifications online in the browser, so you can see, because I'm pretty adept at it, because I use it probably every other day. So and I can show you exactly where to find the information, and we can run through some things. You can give me, for example, a key code or keyword, a term, we can put it in, and I can show you what will result in terms of that particular search. I'm happy to offer that up if we want to schedule something subsequently to help further your cause. As I mentioned, I think I'm now in this mission with you now as a social worker. So I'm happy to do this. So I hope that helps you, and please go ahead, and I'm going to put it in the chat, the link to the ICHI as well.
Okay,
I'll
thank you.
You're welcome.
Thank you, Dr. Patricia. The participant very interactive. And the last question, because we have a limited time, from Marianus. Is there a possibility that the ICHI development model will lead to the emergence of new types of disabilities? Furthermore, our professionalism is also hampered by so many factors, especially government policies and regulation. Is there a way to bridge the progressiveness of this project with the regulatory development that are in fact much later? Okay, please.
Okay, so the first question, I actually think the system does the opposite. That's what I like, the functioning-based system, because everyone functions, right? So everyone has a level of functioning and it changes on a daily basis. It changes even within a day, right? You wake up and you're very energized and you're refreshed from having a good sleep, I hope. And you go on with your day, and by the end of the day, perhaps you're not energized as much because you have been able to work as a medical social worker very hard in your job. And at the end of the day, you're very tired because you've seen lots of patients and clients and so forth. So we know our functioning varies. And so I think it kind of normalizes that. When we kind of take the term disability, let's say out, if you will. I mean, a disability will always be an identity, and it's a very important social identity, but understanding that everybody, part of that is just everyone functions, right? A day to day. And so I think it does normalize and perhaps does the opposite. It helps to establish that this is a classification for everyone, right? It isn't just about working with people with disabilities and people, rather than without disabilities. We work with everyone as social workers, and we work in the area of functioning. We address functioning within health. And so I think that's really important the point of distinction. The second question, I might have missed a little bit of it. It was the question about how do we then combine the regulation with promoting the profession, or could you repeat, Mari, the last part of that question?
Okay, it's enough maybe because we have a limited time. It's very interesting discussion. But before we finish this session, I will give the time for Dr. Patricia to give brief reflection or closing statement.
Oh, sure, absolutely. So it's been a pleasure to learn actually through questions and through the wonderful talks. Thank you so much to Puji and Mari and Verolia. I hope I say the name okay. I know I pronounce it a little bit differently every time I see you. And I'm very happy to learn more about your country situation and to know that you're making inroads, right? You're making progress in integrating social workers and hiring. I think hiring the first few social workers is the key step, right? And as I mentioned, showing the value of social work, looking to other countries who have integrated social work successfully and effectively, looking to them for some data and the evidence that you can utilize and bring into your own country. Still, countries are different, I understand, but still you can use it and you can make some adaptation as needed. I think, working in terms of regulation, there's been several questions on that today, understanding what the regulations perhaps might work within your country and which ones would need to be changed to make it better in terms of more suitable for your country's context. I think also, as I mentioned, working with other professions, helping them understanding and of social work and raising awareness of what social work is and what social workers do. I think it's absolutely critical for increasing the value and recognition of social workers within healthcare space. Looking to those outside of clinical professions, as I mentioned, looking to those who work like health economists, those who are in hospital administration, to understand what matters to them. Ask them, what matters to you? What is it going to take to increase the number of social workers in our hospital, in our healthcare system? And so if you're able to show perhaps how much money you save for that hospital by having a social worker, then they can utilize that money and reallocate it to hiring more, right? So I think these are the things that you need to do. And I do, as you know, embrace the WHO classification systems. I think it's great because it is used in so many countries, and it provides a way that we can share our data and increase health operability, which I think is absolutely key. We need to have portability with our data records, and we need to also bring them into the hands of the people. That's the key. When you do that, when you have the technology and you can build the systems, then you can bring it back to people. And they are the key stakeholders. They're able to utilize that information, have agency over utilizing that information and accessing that information. And so it is a point of empowerment, which is very much a social work approach to. So thank you again. Thank you everyone for having me here. It has been wonderful to see everyone. Everyone, I know it's late at night for you in Indonesia, morning for me, but late at night for you. So thank you for taking the time outside of your workday to be here. And as I mentioned, I'm happy to come back and we can do maybe a more interactive walk through the classifications with some case studies to follow up, but please reach out. And I know already I see some couple of people have reached out to me already through LinkedIn. So I'd be happy to continue the conversation. So best wishes to you all in this very important endeavor that you've taken on.
Okay, thank you so much, Dr. Patricia. And now we invite Dr. Puji Pujiono to give brief reflection for this session. Dr. Puji Pujiono, are you with us? Okay. Maybe the next we will invite Miss Firolia to give brief reflection from this webinar.
Yeah. Once again, thank you so much, Dr. Patricia, for all your insights and also informations. And it's really helpful and very, very applicable here. So hopefully tonight is not the end of our discussions. Hopefully we can continue. And I really hope in the near future we can really collaborate. And I'm really interested with your training, what you develop with your friends. And yeah, as I point out in the room chat, that is very, very crucial for the hospital to know how important to have a medical social worker here. And it's a long there is still a long way to go through, but here we really committed as the Association for Medical Social Workers to really advocate our rights and also to advocate the holistic care for all of our patients. So hopefully, as you said before, as you mentioned before, that in the future, if the patients go to the hospital, so the very first person that they will see is a medical social worker. So I really, really hope that dream will come true. Once again, thank you so much, Dr. Patricia, and also for all the participants here. We're really happy because there are so many participants that not only from the medical social worker but also from several settings. So it's really helpful. It's really I'm so happy to share with you and give the information about medical social worker here for all the social worker around Indonesia who have joined tonight's meeting. So once again, thank you so much. And I'm so sorry if there are some technical issue during our discussion tonight. So hopefully it will you guys can can have so many takeaways, and also we can collaborate more in the future. Once again, thank you so much. Wassalamualaikum warahmatullahi wabarakatuh. See you again, Patricia.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Ms. Firolia. As we wrap up, here are some key takeaways. The first, in Indonesia, social workers remain excluded from healthcare system in terms of billing, coding, and health data. And the second, ecological and system approach, for example, person in environment, are inherent in the ICF framework and classification. And it's so important since social workers practice across other settings and working with other professionals. And the third, individual with the same diagnosis, but their needs are not the same, and their life situation require different types of intervention. So not only health, but also social work and other intervention. And the fourth, global classification like ICF, ICD, and ICHI have codified their contribution. And the last, reform that require both policy advocacy and cross-sector collaboration is needed. To Dr. Patricia, thank you for your sharing, your knowledge, and your passion. I learned a lot about billing system, and I'm so interested to learning more. And I would like to thanks for IPSPI to Dr. Puji Pujiono and representative from Ministry of Social Affairs, Indonesian National Council of Social Welfare, and our partner from university, Indonesian Association of Medical Social Worker, and all participants and organizers. I apologize for any mistake in this webinar session, and I also apologize if there are any questions that were not answered. I would be very happy if Dr. Patricia could spare the time to answer questions from participants outside of this session, for example, via email. And thank you for all the participants. Thank you for your engagement. Stay tuned for our next lectures. Stay safe, stay connected, and stay committed. And I give back this event to Ms. Suhaila to closing this session. Thank you.
All right, thank you to our moderator and speakers. What an engaging and insightful session we just had. Ladies and gentlemen, as we come to the end of the Social Work International Lecture Series, I want to take a moment to say thank you from all of us on the organizing team to each and every one of you. Today's session was a heartfelt reminder of why our role as social workers in healthcare truly matters. We heard how being left out of the hospital billing system and health data doesn't just make our work invisible, it also limits how much we can help the people and the communities we serve. Yes, the challenges are real, but we are not facing them alone. We are in this together, and we are ready to make a change. Our deepest appreciation goes to Dr. Patricia Welch-Selby for sharing such invaluable global insight on how tools like ICD, ICF, and ICHI can strengthen the position of social workers in health systems around the world. A heartfelt thank you to our moderator, Ms. Mari Esterilita, for guiding today's discussion with clarity and care. We also extend our gratitude to Dr. Puji Pujiono, President of the IPSPI, for opening today's session with thoughtful and inspiring reflection, and to IPSPI for its ongoing leadership in strengthening the social work profession in Indonesia. To Ms. Viralia Pramadita Putri, thank you for setting the stage with key perspective from the medical social work community and grounding today's theme in national relevance. And to all our partners, especially the Ministry of Social Affairs, the Indonesian National Council of Social Welfare, APSMI, our collaborating university, and the Social Work Student Association Forum, thank you for your continued support and shared commitment to strengthening the role and the recognition of social workers in healthcare system. And most sincerely, to all of you, social workers, students, academics, humanitarian workers, tuning in from Zoom and YouTube, thank you. Your participation today is a step toward systemic change, toward professional recognition, and toward a future where social work is fully integrated and valued within healthcare system. Wait a minute, we have final announcement for you guys. If you'd like to revisit today's discussion, the recording will be available on the IPSPI YouTube channel. Feel free to share it with your colleagues and networks. For those who wish to receive an e-certificate, please make sure to fill out the attendance form, which has been shared in the Zoom chat box by our organizing team. We are also excited to announce our next International Lecture Series session, which will take place next month on Wednesday, August 27th from 7 until 9 p.m. Jakarta time. Our speaker will be Dr. Daniel McElroy, lecturer at the School of Social Science, Education, and Social Work, Queen's University. She will be presenting on the important topic, protecting client rights. We look forward to seeing you there. Please stay tuned to IPSPI social media for many updates. With that, we officially close today's event. May the conversation we shared today stay with you, inspire your work, and strengthen our collective commitment to justice, recognition, and solidarity within healthcare and beyond. Thank you so much, everyone. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Patricia, thank you and take care.
Thank you. Dr.
Viro.
Patricia,
Thank you, Dr.
We miss you. We miss you.
Viro, Pak Puji, and everyone.
Can somebody do a photo, perhaps? I don't know. Is
Yeah.
anyone able to capture
Yeah.
everyone on the
Sure,
screen?
sure.
No, maybe.
Patricia,
Fun.
we got 115 on the marker.
Good.
Yeah.
Incredible, huh? 115 participants. That's nice.
That's very good. Did someone do it? To do the screenshot, or I don't know how to do it.
Yeah, sure, sure. I will guide the photo session. All right.
No, but I have taken a screenshot of 115.
Yeah,
But
sure. Actually, the highest number is 125, Pak Puji.
all right,
Wow.
I missed that one. Nice,
Plus
nice.
for tonight's session.
Okay.
All
That's
right.
good.
Now, with
You
the
want to take a picture,
remaining
Tricia?
with the remaining participants, I would like to invite you to turn on your camera and take picture together with our distinguished speaker.
Good to see everyone.
Wonderful. Yeah, all right. Okay. So I will guide the photo session. Give your best smiles and best style for a picture. All right, wonderful. Okay, 1, 2, 3, cheers.
The IPSPI.
Yeah, once more. Okay, 1, 2, 3. All right, the second slide. 1, 2, 3. All right. Wonderful. Once again, thank you very much,
All right,
Bapak and
guys.
Ibu, for your participation, and we look forward to meeting you again on
Yes.
next month.
Next month.
Yes,
We have
excellent.
Daniel
And-
speaking next month, and then Lavanya
Yeah.
the month after.
Yes, and then I'll see Danielle after she speaks. I'll be in Ireland, so I'll get to
There
see
you
her.
go. There you
Which
go.
will be,
Have a
which will be
party.
nice. Yeah.
Don't drink too
Well,
much.
yeah, we'll be in touch, everyone. And like I said, I will volunteer to do a walkthrough.
Nice, nice.
As soon as
Thank
I
you
said
so
it, I said,
much.
okay, I'm volunteering myself, I guess, to this. But I think
Nice.
it's because I can walk everyone through and they'll get something very useful out of it. So I'm happy to do that. Just let me know what might work. If you can organize it, that would be great.
Okay.
And then, but yes, perfect.
All right.
All right.
Ciao.
All right.
Bye bye, everyone.
Ciao.
Tisha and the team, let's meet somewhere
Bye-bye.
else.
Yeah,
Tisha and
sure,
the team meet after this, huh?
Yeah,
Yes,
sure, Pak.
absolutely. Okay, bye-bye.
Thank you. Bye-bye. I'd like to
Good
end the
night.
meeting and see you.